Hello and welcome back to another pediatrics session. We are at page 399, USMLE step 3, Masters the Boards, and we are starting with renal and urologic disorders. Before we start, I want to congratulate you on getting this far. We only have like 2 sessions left, and we're going to be done with pediatrics, so yay. Stay encouraged and stay doing what you're doing. Just keep on doing that. And let's just get started. All right. So in renal and urologic disorders, we start with the urinary tract infections in pediatrics, a very important topic. In UTIs, they are more common in boys who are less than 1 year and girls who are more than 2. So in boys, in less than 1 year, and girls more than 2. Most girls, they develop their first UTI by the age of 5. Peaks are during infancy and toilet training. The most common agent is a gram-negative rod. The diagnosis is as with adults. It's the same thing. So the best initial test is going to be urine analysis, and the most accurate one is urine culture, of course. The treatment is going to be different a little bit. If it is cystitis, which we're going to see dysuria, we can give amoxicillin, trimethoprim, sulfamethoxazole. If it is pyelonephritis, we're going to have some fever and flank pain. We should give IV ceftriaxone or ampicillin plus gentamicin. This is going to cover the gram-negative and gram-positives, and both. It's important not to give the following. So, the first one is going to be sulfonamides or nitrofurantoin in infants less than 1 month old, and we should give ceftriaxone instead. Tetracyclines in children less than 7 years, and quinolones in children less than 16 years. And this is for the side effects, of course. It should be noted that children are at greatest risk of kidney damage, including kidney scars, poor kidney growth, poor kidney function, and high blood pressure, especially if an underlying urinary tract abnormality exists. So this is really important. They are at the greatest risk of kidney damage, more than adults. Okay, this is your further management here. What we should do is to do urine culture 1 week after stopping the antibiotics. And this is to confirm sterile urine. And reassess periodically for the next 1 to 2 years. So it's not just give antibiotics and symptoms are gone, then you're fine. No, you should do a urine culture 1 week after stopping the antibiotics. And again, reassess periodically for 1 to 2 years. The next thing is to obtain Boyding cystourethrogram and renal ultrasound in special cases, like in children of any age with more than 2. Or at least 2 febrile UTIs. So if we see a child who has 1 UTI, that's fine. If we have 2 UTIs, then we should do a Boyding cystourethrogram and a renal ultrasound. And I think this is probably just to look for any underlying urinary tract abnormality that might exist and would be causing the urinary tract infections. The second thing that the second condition that we should do avoiding cystourethograms and ultrasound is going to be the first febrile UTIs that has a family history, or in a case that has a family history of renal or urologic disease, if there is a poor growth in the child, if there is hypertension along with it, or the organism other than E. coli. So 4 conditions here. First febrile UTI, if there is a family history of renal or urologic disease, poor growth, hypertension, organism other than E. coli. In that case, what we should do is a Boyding cystourethrogram and a renal ultrasound. All right, that's been the UTI. Now let's take a look at the Vesicoureteral reflux, VUR. I am not sure if I'm pronouncing this right, but you know what I'm talking about. And it starts with a question here. It says a 2-year-old girl presents with a urinary tract infection. She has had multiple urinary tract infections since birth, but has never had any follow-up studies to evaluate these infections. Physical examination is remarkable for an ill-appearing child who has a temperature of 40 degrees Celsius and is vomiting. Voiding cystourethrogram reveals abnormal urinary backflow from the bladder. Which of the following is the most important step to prevent permanent damage? And we have here ACE inhibitors, trimethoprim sulfamethoxazole, non-steroidal anti-inflammatory drugs, regular creatinine measurement, and E, surgical reconstruction. And the answer here is B, which is trimethoprim sulfamethoxazole. And this is the step to prevent permanent damage. It says here that antibiotic prophylaxis in the form of trimethoprim sulfamethoxazole or nitrofurantoins is used for the first year following the diagnosis of any grade of VUR, or the vesicoureteral reflux, particularly in younger infants, to prevent kidney scarring from recurrent infections. And this is the most important step to prevent permanent damage. VUR is abnormal. Is an abnormal movement of urine from the bladder into the ureters or the kidneys. Urine usually travels from the kidneys through the ureter, then into the bladder. In our case, in the ureteral reflux, it's going to be urine flowing in the reverse order. VUR predisposes the child to nephritis, of course, which leads to scarring and so on. And this leads to reflux nephropathy, which would be like hypertension, proteinuria, renal insufficiency, and then finally end-stage disease and impaired kidney growth. So how are we going to diagnose such case? What we're going to do is to perform a voiding cystourethrogram, just like in the question, and we can do a renal scan as well. And if there is a scarring is present, we follow creatinine periodically to see if the child will progress into end-stage renal disease or not. The treatment is going to be antibiotic prophylaxis, like we said before, trimethoprim sulfamethoxazole, and surgery. And this is going to be surgery under the following specific conditions. So when do we do surgery here? First, any breakthrough UTI. If there is a new scar, and finally, failure to resolve. So that's when we do the surgery here. Okay, moving on next, we are going to take a look at obstructive uropathy. Really short account on it. It says here that the first presentation of obstructive uropathy is usually an infection or sepsis. The most common causes of obstruction or obstructive uropathy is going to be different. In boys, it's going to be posterior urethral valves are the most common cause of bladder obstruction. We look for a walnut-shaped mass, which is the bladder, above the pubic symphysis and the weak urinary stream. So this is a common site in boys, and it's going to be posterior urethral valves. The second thing is in newborns. I'm sorry. It's going to be in newborns, and this is a hydronephrosis and a polycystic kidney disease. Those are two things that we see most commonly in newborns. And they are the most common causes of a palpable abdominal mass in general as well. And the best initial diagnostic test in such cases is the voiding cystourethrogram and a renal ultrasound. Okay, now let's talk about hematuria here. Start with the acute post-streptococcal glomerulonephritis and with a question. And the question says here, a 10-year-old boy presents with lower extremity swelling. He has had a sore throat for 2 weeks and a fever, of course. His mother has noticed very dark brownish red urine over the past couple of days. He has no known allergies. On physical examination, his blood pressure is 185/100, elevated. Which of the following is indicated for management? So we have here ACE inhibitors, diuretics, erythromycin, oral prednisone, and penicillin. So we have here different approaches for the management, and And the right answer is going to be penicillin, actually. I actually know that answer without even looking at the answer next. But the answer is actually penicillin, yes. And this is the most appropriate therapy for acute post-streptococcal glomerulonephritis is going to be antibiotics. And this is to eradicate the underlying infection that we had. Penicillin is the drug of choice, of course, but it could be other stuff. We can have penicillin derivatives, as in any question or any other question that would have penicillin derivatives, it would still be the right answer, I think. And somebody would say erythromycin. Well, erythromycin is used, but it's only in patients who are penicillin allergic. So keep that in mind, because it can say in the stem of the question that he's allergic to penicillin, and in that case we would choose C, which is erythromycin. It goes on and says that the acute post-streptococcal glomerulonephritis presents in children 5 to 12 years old, 1 to 2 weeks after the strep pharyngitis, or 3 to 6 weeks after the skin infection. So be aware of that as well. It's not only throat infections, it is also in skin infections. And I think it's a fun fact that that the skin infections or impetigo could cause the acute post-streptococcal glomerulonephritis, but it wouldn't cause rheumatic fever, which is only caused by strep pharyngitis here. Okay, moving on, and it presents with a classic triad of hematuria, hypertension, and edema, just like in the stem of the questions. How are we going to diagnose such a case? Well, of course, urine analysis. That's going to be a standard here. And we're going to see RBCs, RBC CAS, protein, and polymorphonuclear cells. We're going to have a low C3, complement 3. Is going to be low, and it returns to normal in 6 to 8 weeks. So just know that 1.5 months, 2 months after this incident, it's going to return to normal. So it takes some time, and we need positive throat culture or increasing antibody titer or titers to streptococcal antigens. And the most specific test is going to be anti-DNase antigen. I didn't know that part, that this is the most specific test here. Excuse me, I seem to be a little sleepy, but we'll go and power through this session. So the most specific test is anti-DNase antigen. The treatment here is pretty standard. We said penicillin before, or erythromycin, a penicillin allergic, and supportive care. We're going to give sodium restriction, diuresis, fluid and electrolyte management. Antihypertensives are not indicated in acute management. And steroids do not have a role in this management. Probably in like 95% of cases, there is going to be a complete recovery. Okay? All right. And this is the nephritic, or an example of nephritic syndrome. But let's look at other conditions that would present with hematuria here. The first one is going to be IgA nephropathy, or Berger's disease. This is the most common chronic glomerular disease worldwide, and it can present in adolescents, but most commonly in patients in their 20s or 30s, but it can present in adolescents, so that's why we're taking a look at it. They present with gross hematuria after an upper respiratory infection or gastrointestinal infection. So it might resemble the acute post-streptococcal glomerulonephritis. There will be mild proteinuria and hypertension and a normal C3. So it's going to be normal C3, not low like in the EPGN. The most important step in management is blood pressure control here, which is, again, different. Antihypertensives would not indicate an acute management of the acute post-streptococcal glomerulonephritis, but in IgA nephropathy, as it is a chronic condition, the most important step is management of the blood pressure. The second condition here is the Albert syndrome, which will cause hematuria again. This will present in a young boy with hearing difficulties. And asymptomatic microscopic hematuria and intermittent gross hematuria. So it's not only just microscopic, but intermittent also gross hematuria after upper respiratory infections. Family history is significant for males with renal problems. significant for males with renal problems and sensory hearing loss. We look for ocular abnormalities in workup. So this is Alport syndrome. Again, remember the eye, the ear, and the kidneys. Now, moving on next, we're going to take a look at polycystic kidney disease. We have here the autosomal recessive type, which is the infantile type, different from the adult one. And the polycystic disease here, it is suggested when an infant presents with bilateral flank masses and hyperplasia at the same time. We look for the following in the case here. We can look for hypertension, oliguria, and acute renal failure. We can diagnose it by performing an ultrasound of the kidney. We're going to see cysts through the cortex and the medulla, and also the liver. We can have bile duct proliferation and hepatic fibrosis here. So how we're going to treat such a case? Well, treatment is with dialysis and transplantation, of course. Of all patients, 80% have a 10-year survival, which is kind of sad, but this is how it is. So, polycystic kidney disease, autosomal recessive type, or the infantile type. Next, after looking at the hematuria, let's take a look at proteinuria here. In proteinuria, there are some different types here. The first one is the transit type, and this could be kind of like a physiologic type. Sometimes they're called that way, and is usually from fever, exercise, dehydration, or cold exposure. We have another type, which is the orthostatic one. Now, this is the most common form of persistent hematuria in school-aged children and adolescents. And we look for a history of normal proteinuria in supine position, but greatly increased proteinuria in the upright position. We rule this out before any other evaluation is done. So the first thing to do is to have an orthostatic, to look for orthostatic proteinuria if we're going to diagnose a case. The third type is going to be the glomerular or the tubular disorder type. So this is the abnormal type, of course, and we suspect a glomerular disorder with proteinuria that is more than 1 gram per 24 hours. Or if the case would describe other things like hypertension, hematuria, or renal dysfunction. This would indicate that there is a glomerular or a tubular disorder. So, and going into proteinuria here, let's take a look at nephrotic syndrome. And the first thing is minimal change disease. This is the most common type, I think, and it starts with a stem of the question here that says a 3-year-old child presents to the physician with puffy eyes, so edema. The mother reports diarrhea 2 weeks ago. On physical examination, there is no erythema or evidence of trauma, insect bite, cellulitis, or conjunctival injection. There's also no discharge. The urine analysis revealed 3+ proteinuria. Laboratory profile is significant for albumin of 2.1 milligram per deciliter, which is low, and creatinine is 0.9, fine, and a C3 and C4 are normal. Which of the following is the next step in management? I would say nothing really, but let's take a look at the things that we can do. The first is outpatient prednisone. B is hospitalized and observe. C is heparin. D is high-dose methylprednisone. And E is IV antibiotics. And the answer here is A, outpatient prednisone. We're going to give that patient prednisone in an outpatient case. It says that outpatient prednisone is the first step in management of patient presenting with a mild case of minimal change disease. Prednisone is continued daily for 4 to 6 weeks. Then we're going to taper it to alternate days for 2 to 3 months without initial biopsy. So without even having a biopsy, we're going to give prednisone on an outpatient case for 4 to 6 weeks, and then we taper it off for 2 to 3 months. All right, that's minimal change disease so far. It says here that nephrotic syndrome is most common at 2 to 6 years of age, which is different from nephritic, which is 5 to 12, I think. And often arising after minor infections. Like in such a case, he had diarrhea. It presents with the following. It's going to be a proteinuria of more than 40 milligram per meter square per hour. And the creatinine is going to be usually normal, like we had in the case. It's going to be hypoalbuminemia of less than 2.5 gram per deciliter, like in our case. It was 2.1. We're going to have edema, like in the case would describe the puffy eyes, initially around the eyes and the lower extremities, of course. And we're going to have hyperlipidemia. And I think this is due to the hypoalbuminemia here, but we're going to have hyperlipidemia. And C3 and C4 are normal, unlike the nephritic, which you had the C3 in the acute post-streptococcal glomerulonephritis, we had C3 low. How to treat this condition as follows. First, there's going to be supportive care like sodium restriction and fluid restriction, just like in the acute post-streptococcal glomerulonephritis. We're going to give oral prednisone and on an outpatient case, like we said before. Relapses on steroids may indicate that the patient is steroid dependent or either resistant. The patient should receive cyclophosphamide, cyclosporine, and high-dose pulsed methylprednisone in such cases. Following are the following things that I'm going to mention are complications that we might see in nephrotic syndrome. Of course, we can have infection, and this is due to the low protein. So the most frequent is going to be spontaneous bacterial peritonitis. Due to this, we must immunize against pneumococcus and varicella. There's also going to be an increased risk of thromboembolism due to increased thrombotic factors and decreased fibrinolytic factors. So we're going to have thromboembolism as a complication. So again, the two complications is infection and thromboembolism, and both are due to the decrease in protein in the body. All right, so this has been the kidney or the renal section, along with the urologic disorder. We have here the endocrine disorders. We're going to go through it, and then we're going to stop. Okay. All right. So endocrine disorders. The first thing we're going to take a look at is the congenital adrenal hyperplasia. Congenital adrenal hyperplasia refers to a group of autosomal recessive disorders. And that result in inadequate cortisol and or aldosterone synthesis. We have multiple ones, but the most common is the 21-hydroxylase deficiency. I would highly suggest that we take a look at first aid for the step 1. For this, they have a beautiful illustration and a table for it that you can memorize and take a look at it. It would help a lot because this has been like a really confusing topic in step 1, and they manage it really well. So if you would like, you can take a look at that. But let's just go through what is written here. So the most common type, again, is the 21-hydroxylase deficiency, and in which there's going to be a decreased production of the cortisol, and this will lead to increased ACTH, of course, and the increase in ACTH is going to have effect as an adrenal hyperplasia, and this is going to lead to shunting to androgen synthesis, as we're not able to produce cortisol, so we're going to have more androgen. And the more androgen is going to lead to masculinization of the external genitalia in females. That's why we're going to see an ambiguous genitalia for females. All right. So the next thing here is a really good illustration here of the process of getting aldosterone and cortisol, or the synthesis in 21-hydroxylase deficiency. And we have here a problem that the 21-hydroxylase is not going to be able to convert progesterone into deoxycorticosterone, and later on this leads to the aldosterone deficiency. And the 21-hydroxylase is not going to convert the 17-alpha OH progesterone into 11 deoxycortisol, and this finally leads to a deficiency in cortisol. Of course, you do not have to listen to those. Just take a look yourself so you wouldn't be confused. It doesn't really matter. I don't think you didn't have to memorize all of these, but just in case you have a question on it, and they probably would do that. I don't know why, but I just feel that they would do this and ask a question from step 1 in this specific case on the exam. So I will probably just take a look at it because it has been highlighted and it's a high yield topic in step 1. So, okay. And so let's continue here. And it says that in 21 hydroxylase deficiency, the patient cannot convert progesterone into deoxycortisone, like we said, and this is going to lead to the deficiency in the corticosterone. And the patient also cannot convert 17 alpha hydroxyprogesterone into the 11 hydroxy deoxycortisol, and this is going to lead to the low cortisol level that stimulates the ACTH and so on to produce more. The result is a buildup of progesterone and androgens, and this is going to cause the masculinization of the genitalia, like we said before. Congenital adrenal hyperplasia is going to be presented in infants, and that with a sign. With the following signs, we're going to see a patient who has vomiting, dehydration, hyponatremia, salt losing, and this is due to the hypoaldosteronism, hypoglycemia, because we have hypoglycemia here, and hyperkalemia, and the females are going to have ambiguous genitalia at birth. Hyperkalemia and hyponatremia are due to the aldosterone, and I believe hypoglycemia is going to be due to the cortisol. And the diagnostic testing here, and but I'm not sure really why hypoglycemia would be due to the cortisol here. If you understand this or know why, please leave a comment below letting me know why. This would help me and others as well. Okay, so how are we going to diagnose such a case? Well, the best initial test is going to be increased 17 hydroxyprogesterone. We'll also find low cortisol levels, increased renin, and decreased aldosterone. Those would be the best initial test here, is an increase in 17-OH progesterone. The definitive diagnostic test is 17-OH progesterone before and after an IV bolus of ACTH. And we can see the difference here. All right. How are we going to treat such a case? We're going to treat it with hydrocortisone and the fluorocortisone if there is salt losing. We would increase, which is just mineralocorticoids in general, increased doses of both hydrocortisone and fluorocortisone in times of stress, because this would be simulated, or it's like a simulation of the normal function. And finally, we have a corrective surgery for females. All right, and again, I would really highly recommend that you would take a look at first aid for step 1 for the congenital adrenal hyperplasia for this type and the other types as well, and have a better grasp on it. All right, so this has been the kidneys or the renal issues, along with the endocrine disorders, and we're going to stop here, and next we're going to have rheumatic and vasculitic disorders, and it's going to be probably our last section here. All right, take care, study hard, and I'll see you in the next one. All right, bye-bye.